Hello, I'm Tatiana the doula, and I am here to continue my readings of the Lactation Counselor training course notes. So these are the handouts from the training course. I just want to preface that this is not a substitute for actually taking the course. You need to view all the videos. It's a 52-hour course. I'm simply reading this because it's easier for me to digest on the go, and I like to be able to reference it. And I actually literally was just listening to my other videos when I was taking a drive this past few days. I was listening to the audio of some of the handbook. So I'm going to continue on with this, reading the notes for 2A. Negative influences on milk production, long spaces between feedings, long, slow feedings, excessive pressure in the breast. Pressure can result from vascular, lymphatic, and third spacing forces, especially early on. Secretory activation, lactogenesis 2. And then there's a versus chart here. It's like a versus normal fullness versus engorgement. So normal fullness is a breast is soft to touch, body temperature is normal, the mother feels well, breast may be hot, baby can grasp the nipple. Versus engorgement, the breast is hard, the temperature is normal or elevated, that feels discomfort, the breast is hot and shiny, and the nipple is difficult to grasp and the baby can't latch. Engorgement symptoms occur most commonly between days 3 and 5, but mothers who have had IV fluids in labor and postpartum have higher levels of swelling up to day 9. Women with cesarean births experience peak engorgement 24 to 48 hours later than those who deliver vaginally. More time spent breastfeeding in the first 48 hours is associated with less engorgement. ABM protocol number 20. The process of engorgement results in pressure building up inside the breast. As the pressure inside the breast increases, milk production decreases. This is nature's early lactation dry-up mechanism. Failure to effectively resolve prolonged symptomatic engorgement may have a negative impact on continued adequate milk supply. ABM protocol number 20. Pressure can result from vascular, lymphatic, and third spacing forces, especially early on. Secretory activation, lactogenesis 2. Too much milk left in the breast, missed feedings, restrictive bras and clothing, breast implants. With implants, concern centers on storage capacity reduction, significantly greater incidence of lactation insufficiency with implants versus no implants in a controlled study. Women with implants were less likely to establish breastfeeding, especially exclusive breastfeeding. Negative influences on milk production: long spaces between feedings, long, slow feedings, excessive pressure in the breast surgery or injury. With surgery, concern centers on damage to nerves, damage to ducts. The periareolar incision can extend all around the areola. Look for the defined margin where the color changes from areola to breast. There are many breast reduction surgical techniques. Free nipple graft, pedicle. Women who underwent breast reduction surgery compared with controls had a significantly shorter time of exclusive and any breastfeeding. Chest masculinization or top surgery. Transmasculine individuals experiences with chest feeding. Out of 22 participants, 16 chose to chest feed for some period of time after pregnancy. Wide range of experiences, no single experience. Some participants had not had chest masculinization surgery prior to pregnancy and lactation. Restarting testosterone and binding were common concerns. Care providers should communicate an understanding of gender dysphoria and transgender identities in order to build trust and provide transgender competent care. Counseling implications after breast surgery. Likelihood of full breastfeeding is unknown. The hormonal exposure of pregnancy and lactation may mitigate some effects of surgery. Assessment and close follow up are the keys. Assure adequate nutrition for the infant. Negative influence on milk production, long spaces between feedings, long slow feedings, excessive pressure in the breast surgery or injury, suboptimal breast anatomy, anatomical, suboptimal breast anatomy, and then there's sub bullets. Anatomical concerns, absence of breast changes in pregnancy or early days of postpartum, no postpartum breast fullness or signs of abundant milk production, hypoplastic breasts, discrepant breast size. One implant may indicate that there was a discrepant breast size. Any abnormality, breast surgery, and/or breast injury may impact breastfeeding. Counseling mothers. Assure privacy. Ask about surgery, improvements, or injury. Determine innervation sensation. When counseling, ask yourself, are the ducts patent? Are the nipple pores patent? Are there signs of hormonal connection? Are there concerns about weight gain of baby? Is there adequate pediatric supervision? With flat or inverted nipples, will the hormones function optimally? Prolactin equals nipple stroking. Oxytocin equals nipple stretching. Smith et al. Imaged the nipple using ultrasound during breastfeeding at the University of Iowa. The nipple stretches 1 time to twice its length, and then it is stable in length. The nipple expands in diameter into the open mouth to accommodate optimal milk flow. The nipple compresses during the swallow. Babies don't need a nipple to latch onto because it is their job to form the teat. May evert in pregnancy, may evert in postpartum. Flat nipples always evert during suckling. Both may evert sometimes. Sexual stimulation, finger manipulation, cold. Inverted nipples classification adapted from Han and Hong. Grade 1 are easily pulled out with a breast pump or infant nursing. Grade 2 can be pulled out but don't maintain their projection. Grade 3, difficult or impossible to pull out. The classification is about function during feeding, not about how inverted or flat the nipple looks at rest. Grade 1 and 2. 2 would go back in rapidly. Grade 3 inverted nipple before and after are the same. Cooper et al.'s 5 Sentinel cases. 5 mothers, 5 hospitals, 5 pediatricians. 3 out of 5 mothers had inverted nipples. 4 out of 5 mothers reported engorgement. 5 out of 5 mothers leaked milk. 4 out of 5 mothers had documented breast changes in pregnancy. I'm just trying to see if I have one. 3, 4, 5, 6. Okay. Women with uncorrected grade 3 inverted nipples had lower prolactin levels and less milk. Does prenatal nipple preparation make a difference in improving inverted nipples? Not according to research. Counseling implications where there are inverted nipples. Ask if and when nipple everts. Look over the shoulder just after feeding for nipple eversion and compare to pre-feeding nipple. If not seen, intensive follow-up. Consider expression. Assure adequate nutrition of infant. Postpartum eversion techniques such as shells, everters, shields, and pumps have not been studied in prospective experimental controlled trials. Check that gadgets are FDA approved and have safety and efficacy studies. Negative influence on milk production. Long spaces between feedings, long slow feedings, excessive pressure in the breast surgery or injury, suboptimal breast anatomy, suboptimal or altered physiology. Iron, this is a sub bullet of suboptimal or altered physiology. Iron deficiency anemia has been associated with milk supply problems. This may be physiologic, poor oxygen to milk making cells, due to exhaustion or depression altering parents' coping behavior, a combination of the above. More than 20% of postpartum U.S. women have iron deficiency anemia. Hemorrhage can result in anemia in Sheehan syndrome. With Sheehan syndrome, the pituitary has been deprived of blood and its functions are impaired. Can happen even if postpartum hemorrhage has been well managed. Other symptoms include low blood pressure, anemia, fatigue, profound hair loss, dry, dull hair, etc. Some symptoms may take more than 30 years to develop. It may be possible to have low-grade or transient Sheehan-like symptoms that resolve fully or partially. Hormone imbalance, thyroid imbalance, hypo and hyper. Maternal obesity and overweight. First 7 days only, delay in lactogenesis 2, increased odds of early weaning, but increased support resulting in increased breastfeeding duration and intensity. Insulin dysregulation, prediabetes, GDM and diabetes during pregnancy, glucose intolerance but higher lactation intensity and longer duration are associated with lower DM odds after GDM. PCOS. 1 in 10 women may have PCOS. Excess insulin increases production of androgens. High androgens can cause acne, excessive hair growth, weight gain, problems with ovulation and lactation. Some women with PCOS have no visible signs. Some case studies suggest treatment with metformin during lactation may increase milk volume, others do not. Some drugs can alter physiology. Pseudoephedrine, a single 60 milligram dose, decreased 24-hour milk production by 24%, probably by decreasing prolactin levels. Corticosteroids, temporary suppression of lactation for 24 to 48 hours after a local injection of 24 milligrams of prednisolone in a breastfeeding woman who was 6 weeks postpartum. Corticosteroids such as betamethasone, for example, celestone. Smoking alters physiology. Smoking makes mothers make less milk. Smoking mothers may have lower prolactin levels. Pump-dependent mothers of preemies collected less milk if they smoked. Women who smoke more wean earlier. Smoking and nursing may result in babies who nap less. Quitting smoking during pregnancy is significantly associated with reduced risk of premature birth. Pregnancy is a time when many are motivated to quit smoking and provide targeted smoking cessation interventions at this time, which take into account factors predictive of quitting smoking, are more likely to be successful. Support to quit smoking should help to prolong breastfeeding duration, especially those most at risk for not exclusively breastfeeding. Nicotine patches. The FDA 2015 states women who are pregnant or breastfeeding should use these products only with approval from their healthcare professional. Cadmium exposure can affect the kidneys, liver, lungs, and nerves, as well as other body systems. Cigarettes have CD, and this is the primary exposure route in humans today. The newest assumption is that 22% of sudden unexpected infant death, SUID, can be directly attributed to maternal smoking during pregnancy. Breastfeeding may make less severe, the adverse effects of smoking during pregnancy on the child's cognitive development. Apart from support to stop or diminish tobacco consumption, encourage breastfeeding and protect the baby from secondhand smoke. Electronic cigarettes. The use of e-cigarettes in breastfeeding mothers is understudied, but the transfer of nicotine from e-cigarettes appears minimal and less than or equal to nicotine inhalers. What about cannabis? Exposure of infant to any kind of passive smoke is a concern. There is no safe threshold limit for cannabis use in pregnancy. Among pregnant women, cannabis use was significantly associated with an increased risk of preterm birth and low birth weight. The high fat solubility of cannabinoids makes them difficult to analyze in breast milk. A9 THC or 9-THC is still measurable in milk about 6 days after maternal marijuana use. Opinions vary. This makes policy making difficult. Anemia. Postpartum hemorrhage, Sheehan's syndrome, hormone imbalance. Retained placental fragments, lactogenesis stage 2, secretory activation, onset of abundant milk, happens only after the dramatic fall of progesterone that happens with the complete delivery of the placenta. Stage 1 occurs during pregnancy. Nursing during pregnancy. Is nursing during pregnancy safe for the fetus? A Japanese study indicates that it is safe for women who are not at risk for premature delivery to nurse during pregnancy. Tandem nursing definition. Nursing two babies not from the same pregnancy. Milk volume increases faster, but less engorgement is experienced with two nurslings. May require specific teaching to manage faster flow. How parents respond to different needs of each child. Nurse newborn first and frequently. First time for non-nursing interactions with older babies. Find time for non-nursing interactions with older babies. Negative influences on milk production. Long spaces between feedings, long slow feedings, excessive pressure in the breast surgery or injury, suboptimal breast anatomy, suboptimal or alternate physiology, physical objects. Pacifier use may be an indicator that parents need extra breastfeeding teaching. Why is the pacifier being used? Sore nipples, hunger, crying, sleep problems? From AAP's policy statement on SIDS to 2016, consider pacifier use at nap time and bedtime. For breastfeeding infants, delay pacifier introduction until breastfeeding has been firmly established. Pacifiers for preemies may have earlier hospital discharge. Tube-fed babies may gain faster with pacifiers and have improved physiologic and behavioral responses. Reduce the time to full oral feeds. Nipple shield use has raised concerns. What about bottles of water and formula? Among women intending to exclusively breastfeed, in-hospital formula supplementation was associated with nearly 2 times greater risk of not fully breastfeeding on days 30 and 60 and a nearly 3-time risk of stopping breastfeeding by day 30. Why did 1 ounce of formula per day lead to giving up breastfeeding? They did not call for help. They gave a bottle first instead. They lacked confidence in their milk supply, baby getting enough, breastfeeding in general. Depression. Women who are more likely to wean early are those who have experienced depression either during pregnancy or postpartum. Early cessation of breastfeeding or not breastfeeding was associated with an increased risk of postpartum depression. One moment. Among women with breastfeeding difficulties, women who had a negative experience with breastfeeding support had a significantly higher risk of postpartum depression. EPDS, Edinburgh Postnatal Depression Scale, widely recognized as an excellent screening tool, easy to use and score, can be used by any provider. Mothers with a high EPDS, greater than 12, are more likely to discontinue breastfeeding by 4 to 12 weeks, be unsatisfied with their infant feeding method, experience significant breastfeeding problems, report lower levels of breastfeeding self-efficacy, confidence. Women with negative early breastfeeding experiences were more likely to have depressive symptoms at 2 months. Confidence is key. Breastfeeding discontinuation at 2 weeks was associated with a lack of confidence and ability to breastfeed on day 1 and 2. Counseling implications when there are fears about milk supply. Approximately 40% of U.S. breastfeeding mothers have fears about milk sufficiency. Avoid giving inappropriate reassurance. Gather facts instead and refer as needed depending on your scope. Undertake a complete evaluation, including history and feeding assessment, before coming to conclusions, since low milk supply rarely has one cause. Provide adequate postpartum support to distinguish between real and perceived cases of insufficient milk. Establish a community-wide system eliminating the zone of professional unavailability, especially days 3 to 7. And that is the end of the notes handout for notes 2A. Thanks for listening.